Good morning, everyone. Welcome to our hybrid grand rounds. As you know, we start our grand rounds with a land acknowledgement, recognizing that Stanford sits on the ancestral land of the Mwekma Ohlone tribe, and that this land continues to be of great importance to the Ohlone people. Consistent with our values of community and inclusion, we have a relationship and responsibility to acknowledge, honor, and make visible the university's relationship to Native people. On the next slide, today's session focuses on Native American Heritage Month, creative Native American pathways to diversify the healthcare workforce to address health disparities and inequities. Our upcoming grand rounds next Thursday is Thanksgiving, so on Friday we won't have grand rounds. And then the following week, we'll have Philip Zeitler from the University of Colorado School of Medicine to talk with us about youth onset type 2 diabetes, the unique clinical, social, and public health implications. And today we have Dr. Allison Empey with us. And Dr. Empey is a general pediatrician who focuses on newborn care, Native American health, and pathways into medicine and mentorship for underrepresented in medicine trainees. She loves working with patients, medical trainees, and staff from all different cultures and backgrounds. She grew up in Oregon, and she's a citizen of the Confederated Tribes of the Grand Ronde, where her clinical practice is located once a week. She's an assistant professor in the Department of Pediatrics and the Division of General Pediatrics at Oregon Health and Sciences University. And she also serves as the Vice Chair of Equity, Diversity, and Inclusion in the Department of Pediatrics. Additionally, she's the director of the Y East Post-Baccalaureate Pathway, which is a pathway that's specific to Native American students, and the Northwest Native American Center of Excellence in the Department of Family Medicine. She also serves locally as the chair of a national committee for the American Academy of Pediatrics for American Indian and Native youth. And at the local level, she's been involved in educating providers who serve Native youth and serves in her own tribal community as a pediatrician. And so with that, I'll ask Dr. Impey to join us.
All right, perfect. Well, thank you so much for that introduction. And I'm so happy to be here today. And I just wanted to start off by thanking Dr. Floyd for inviting me here, and then also Ingrid and Serena for your assistance this morning. So I don't have any financial disclosures, but I do have some personal disclosures. So today we're going to talk about historical traumas in order to understand the context of American Indian Alaska Native health inequities. And when we're talking about these health inequities, this is not just a group of people I'm describing. These are my ancestors and these are my relatives. So this is a really personal talk today. And as mentioned, I'm a citizen of the Confederated Tribes of Grand Ronde. That is one tribe out of over 570 tribes. So I do not represent all American Indian and Alaska Native people. And today I had my formal academic introduction, but if I were being introduced culturally, I actually would start my introduction by introducing who I'm related to, my relatives. I also would do a place-based one. So today I'm going to spare you. I'm not going to tell you who my great-grandparents and grandmothers and all of that, but I am going to introduce you to my land. So this is Spirit Mountain, and this is found on my reservation in Grand Ronde, which is about an hour and a half southwest of Portland, Oregon. And I travel there once a week to provide care. And every once in a while, I'm able to escape during my lunch and go on a walk. And I often look up at Spirit Mountain and remind myself why I'm doing this. And that my ancestors also looked up at this mountain and that they're giving me strength to do this work. So we've already had a land acknowledgement, so I'm not going to do that. And I was so happy to see that you did a land acknowledgement for each one of your grand rounds, and that's something I definitely want to take back to my university. But I also wanted to personally thank the Mwekma Ohlone tribe for allowing me to be here today on their land. So today we're going to be reviewing the health inequities that exist for American Indian Alaska Natives. We'll compare Indian health service to other healthcare systems, and then I want to spend some time describing current efforts and pathways to increase the number of American Indian Alaska Natives going into medicine, particularly at OHSU at our Northwest Native American Center of Excellence. So first, I'm going to start off by talking a little bit about terms because we have been using them interchangeably already throughout this presentation. And so I'm starting off with Indigenous people. So there actually is no common definition for Indigenous people, but the UN describes it as a distinct social and cultural groups who share collective ancestral ties to the lands and natural resources where they live or where they've been displaced. So really, it's the original inhabitants of a land prior to colonization. American Indian and Alaska Native are Indigenous people from the lower 48 or from the state of Alaska. But these are really important terms because they're actually political designations. So for people who are American Indian Alaska Native, who are citizens of federally recognized tribes, we have a unique political status, not just a race. This status is established by Congress, the Constitution, and treaties, and has been affirmed by the US Supreme Court for over 200 years. And this is why I won't have time to talk about this, but it's in the news. But this is why the Supreme Court hearing on ICWA, or the Indian Child Welfare Act, is so vital and so important. So I encourage you all to look into that. The term Native American is really a term that came out in the 1970s, and it is used more as a way to encompass all Indigenous people from America. We often use it when we talk about American Indian, Alaska Native, and Native Hawaiian, but it doesn't have a political designation. And then lastly, federally recognized tribes. So what exactly does this mean? This means that the federal government sees a tribe as a sovereign nation. And because of that, because of treaties signed by our ancestors, there's a federal obligation to provide services such as healthcare. So I often get asked, okay, so should I use American Indian? Should I use Native American? What should I use? And really, I encourage you all to ask and follow. Many people actually would rather be introduced as their tribe. And I would also encourage you to ask how to say that tribal name, because one, it can be complicated, but two, sometimes the names have been given by the colonizers rather than by the tribe themselves. So talking a little bit about demographics. In 2010, about 1.5% of the population identified as American Indian Alaska Native, either in alone or in combination. And by 2020, 2.9% identified. So we're one of the fastest growing races and ethnicities. About 3/4 live off of reservations, so either right off the reservation land, but many actually live in cities. And in fact, Portland is the 9th largest urban Indian population. And this is from a photo taken from Dancing in the Square that we just were able to have again, bring back in person in 2022. As I already mentioned, there are 574 federally recognized tribes in the US in 37 states, but there are many more unrecognized tribes who are fighting for recognition. Additionally, some people ask why just 37 states? That is often because they have been removed from that land. And that has important implications when you think about legislation as well. There are many states that don't have representatives with federally recognized tribes when we're thinking about policy. In Oregon, there are 9 federally recognized tribes. In California, there are 109. So we're going to talk a little bit about health disparities today, but I always put this quote up to remind ourselves that we are not just the health inequities that exist. We have endurance, we have survival, adaptation, and creativity in the face of overwhelming obstacles, and we have enormous contributions to this country. I'll give you a minute to finish reading that. And so I had planned on talking a little bit about American Alaska Native child health inequities today. And I will talk a little bit about this, but I don't really want to focus on this because I think we all have seen these during COVID and they've really been brought to light. And so I don't want to spend too much time on this. But I do want to point out that adverse childhood experiences, there have been studies that show that American Indian Alaska Native children 1/4 of them experienced 3 or more adverse childhood experiences. And as we know, the more adverse childhood experiences you have, the worse your health outcomes when you become adults. The other thing I wanted to point out is some of the effects of COVID. So while children have been relatively healthy during this time, not affected as much as adults, um, they have been affected by orphanhood. So this was a study that came out in Pediatrics, and it's from December of 2021, and it looked at people or children who had lost caregivers for 15 months. And they found that compared to white children, American Indian Latina children were 4.5 times more likely to lose a parent or grandparent caregiver. And 1 out of every 168 American Indian Latina children lost a primary or secondary caregiver. And this, I think, is incredibly important in Native communities. Often it's not just the nuclear family that's raising a child, but the aunties, the grandparents. And I see that often in my tribal clinic when patients come in with their aunts, with their um, grandparents, with their cousins. And so I think this is an unrealized impact of COVID-19 on children. So why do these health inequities exist? This is a big jumbled thing because this is often how it feels. And obviously, if there was one simple answer, there would be a simple solution. Um, but it's not. This is a nice graph from Kaiser Family Foundation looking at the social determinants of health, and they've added in racism and discrimination. So really, like the systemic and institutional racism that exists. I would also add in for American Indian Alaska Natives historical trauma as well. But when I think particularly about Native Americans, um, I think about some of the policies, historical policies that have placed reservations, often in rural areas, on lands that have unwanted, away from urban areas. So thinking about um, economic opportunity and jobs. I think about food deserts, and then lastly, the healthcare system or Indian health services. And so I think one of the things I always like to point out is when you think about, okay, access to safe drinking water, like that's just a given here in the United States. And we often don't think about it here in the US. But this is actually a tribe in Oregon that every single year there's some newspaper article about their access to safe drinking water. So this is the Warm Spring Reservation, and it's about 2 hours away from Portland, or maybe 2.5, depends on how fast you drive. But as you can see, um, they don't have access to safe drinking water regularly. And it doesn't just affect their ability to wash their hands during COVID, to drink water, but it also is affecting their culture as well. This is one that was a time when they were trying to do the root feast and weren't able to do that. And this is just reminding us how close Warm Spring is to Portland, which is the largest city in Oregon. And so I wanted to talk a little bit about Indian health services and why we need more American Indian Alaska Natives going into healthcare. But when I started thinking about this, I realized that we needed to talk a little bit about the history. And to do that is to talk about some of the historical trauma. It'll also help put some of the health inequities in context and help us understand the structure of Indian health services and why that we need 3 different structures for Indian health services, which is federal, tribal, and urban. So today we're going to talk about Oregon tribes in particular, because that's the oral history that has been passed down to me and that I know the best. But I want to remind everyone that many of the policies that we talk about today affected tribes across the United States and in California. I also want to remind everyone that this can be particularly triggering, so a reminder to take care of yourself. So this is the state of Oregon prior to colonization. And there were over 12 dozen tribes. As I've mentioned earlier, there are now only 9. They have been consolidated down. And there were 12 different languages that were spoken. Like California, Oregon has many different geographic regions. And really, these regions help determine a tribe's culture, their ceremonies, their traditional foods, their technologies, whether they were stationary or migratory. And so we had coastal, we had river, we had plains, and we had different desert tribes. But one thing that was the same across all of these tribes is the idea of land ownership. There wasn't land ownership because how could you own land when it's a living and breathing thing? Um, so with 1850, there was a mass migration of people to Oregon, white settlers. And about the same time, there also, I think, the California Gold Rush was going on, and so there was mass migration to California as well. So they want to encourage people to go to Oregon too. And so they did the Oregon Donation Land Act. And so this is about the 1850s. This gave married men 320 acres, and women, if they were married, 320. Couldn't get any if you were unmarried. So that's, a discussion for another day, another lecture. But I wanted to show this map here because I just find that it's so interesting that we see the impacts of this today. So they gave away this land in checkers. And as you can see, this is a Google map. Looking at it, you can still see this today, the public lands versus the private lands. And you can see that it's much easier logged on the private land. So you can see it actually in the map. But as you can imagine, with all these people moving to Oregon and it being given quote unquote free land, when there was already inhabitants living on this land, led to a lot of conflict. With people moving here as well came a lot of new diseases, as we have seen in our current pandemic. A new introduction of diseases can be devastating, and it was devastating for many tribes. And so there was introduction of diseases, influenza, measles, smallpox, tuberculosis, and so many tribes, because of this, because they had lost men to the violence, because they had lost elders, children to the different diseases, signed treaties with the US government in order to stop the violence and to move to a reservation that was going to be provided for the US government where they could live. I'm going to talk a little bit about one of those treaties because that impacted my tribe in particular. That's the coastal treaty. And so it was supposed to include 105 miles along the coast and include over 1 million acres. In addition to receiving this land, tribes were also promised services as well. Unfortunately, this treaty wasn't ever ratified. So that means that by the time that it got back to the US government, they didn't sign the treaty. But by this time, my ancestors, my tribe from the Umpqua tribe, had already moved to a holding land or holding reservation until this new coastal treaty, or coastal reservation was ready. And as you probably saw from the map, there is no coastal reservation. And in fact, it's two much smaller reservations that we see now, the Siletz and Grand Ronde. So this is Table Rock. This is down in Southern Oregon. This is where they moved many of the tribes when they got them to sign that coastal treaty. And like I said, this is a very personal story. Sorry. These are my ancestors. This is Solomon Riggs and Jenny Riggs, and they were actually here at Table Rock. And in fact, my nephew, Solomon, is named after Solomon Riggs. But during the winter of 1856, they were marched nearly 300 miles from Southern Oregon up to what is now the Grand Ronde Reservation in February. Have any of you been to Oregon in February? It is not a place that you want to be marching over 300 miles, and it took them 33 days. And so we often learn about the Trail of Tears for the Cherokee Nation, but many tribes have their own Trail of Tears. Like I said, I would share a little bit about the changing policies. And so the US government at first worked on eliminating and containing Native Americans. But then they decided, okay, let's work on instead assimilation. And one such tactic was Indian boarding schools that also started in the later half of the 18th century. And so this is a photo taken from Chamawa Indian Boarding School. This is the longest running Indian boarding school in the US. It is located in Salem, Oregon. But really, Indian boarding schools were created with the motto, kill the Indian, save the man. And so children were often taken away from their families as young as 5 years old. They were brought to these schools where their hair was cut. They weren't allowed to wear their traditional clothing. They changed their names. They couldn't speak their language or practice their culture. And if they did, they were often punished. Recently, there has been a report that has come out about Indian boarding school that was commissioned by the Department of the Interior. And I encourage you all, this is just the first chapter that has come out, but it highlights some of um, the negative things that were happening at many of these boarding schools. And I think we haven't quite yet realized the long-term impact this has had on generations. But when you think about it, we're taking, as a pediatrician, you're taking children away from their nurturing environment, their parents, all that love and support that they receive. And then additionally, you're taking away their culture, their identity. And we know that Native American identity is protective. So my grandma actually attended Chamawa Indian boarding school. Um, by the time that she went there in the 1930s, policies had changed. You weren't punished, but she was taught not to be proud of being Native American. And so she didn't learn much of her culture. Um, and so that unfortunately was passed down to my mom as well. Another policy that the US government had for assimilation was termination. Um, and so in 1950s, the US government terminated a number of tribes in the United States. My tribe was one of them. This was also the same time that my mom was born. And so not only did her mom not learn to be proud to be Native American, but her tribe was terminated. So what did that mean? That means that the US government said, you're no longer a federally recognized tribes. We don't owe you any of those services. We're going to take your reservation land, which is a gathering space for many cultural activities. We're going to break it up into land allotments and we're going to give it to families, or we're going to move Native Americans into urban centers so that they can find jobs and have more economic stability. And so not only did my mom not receive cultural knowledge from her mom, but during this time, she wasn't able to receive it from her community as well. Many tribes have fought for the ability to be restored. And so in the 1980s, my tribe was restored. And many of the tribes across the United States today are still trying to be restored and be federally recognized. And this is just a photo here. We are our tribe and many of the tribes that have been terminated have a cultural revitalization. So learning to get back to our healthy ways of living. And so let's bring this back to healthcare. So just as a reminder, because many of the treaties that were signed, there's a federal trust responsibility for the federal government to provide healthcare. This was at first provided by the War Department. Very ironic, and they did not have much incentive for that. In 1849, the Bureau of Indian Affairs was passed to the newly formed Department of the Interior. This was also around the time that assimilation policies were happening, and this was pretty devastating for tribal health. Um, the Snyder Act of 1921 was explicit legislative authorization for federal health programs for members of federally recognized tribes. So this is the first time money was going towards this. In 1928, the Miriam Report came out, and this was commissioned by the Institute of Government Research. And it really called out the failure of the US government to provide healthcare and education for American Indian Alaska Natives. And so through this, in 1954, Indian health was moved to public health services, and in 1955, Indian Health Services, and what we have now was established. And so then during the 1970s, self-determination became more popular in policymaking. And so in 1970s, the Self-Determination and Education Assistance Act was passed. And this allowed tribes to take ownership of their own health. And so to receive funding from Indian Health Services, but run and operate their own healthcare systems. So this actually is what my tribe has chosen to do. And there are many tribes here in California are tribally run and operated, and they're often called 638 clinics. And then in the 1970s, the Indian Healthcare Improvement Act, it did many things, but one of the things that it did do was establish the urban Indian healthcare system because there were so many Native Americans living in urban centers. And so I just wanted to review some of that to put the context of why we have these three different structures for Indian health services in place. And we often refer to them as ITU or IHS, which is the federally run and operated, T, which is the tribally run and operated, and then the urban Indian health programs, U. So there are 12 different areas within IHS. And so I happen to practice in the Portland area. And we have 43 federally recognized tribes there. We have 24 tribally run and operated clinics. We have 6 federal, and we have 3 urban. If you did the math there quickly, I'm sure you didn't because I couldn't do that. I had to add it up later. You will see that there are not enough clinics for the number of tribes. And so when you think about access to healthcare, it is a real problem in Indian health services. Another thing is that Indian Health Services is chronically underfunded. We are taking care of some of the sickest, chronically ill patients, and we receive less money per capita than many other government healthcare systems. And so this is a graph showing Indian Health Services compared to the VA and Medicaid from the most recent data, which is 2019. And as you can see, IHS receives almost half. Also looking at IHS provider vacancies. So this is from 2017, looking at the IHS federal sites. So this doesn't even include tribal or urban sites. And they had a 25% vacancy rate with some areas as high as 30%. And so when you think about what that means for patients, that means long wait times. When you think about what that means for providers, overpaneled, burnout, high turnover, which in turn isn't great for patient care. And so what is one of the solutions? So it is helping to diversify the healthcare workforce. American Indian and Alaska Natives are more likely to go back and serve their community. Unfortunately, American Indian Alaska Natives are severely underrepresented. And so this is a pie graph from the AAMC from 2018. And it's looking at all active physicians by race and ethnicity. And if you can see that little tiny sliver, 0.3% identify as American Indian Alaska Native. And when you think about the percent of the population, 2.9% right now. And so, one thing that we are doing at Oregon Health and Science University is working to diversify the workforce by increasing the number of Native Americans going into healthcare. And we're doing that through the Northwest Native American Center of Excellence. And so this is a HRSA grant. The PI is Dr. Eric Brote in the Department of Family Medicine. And I'm fortunate enough to have worked for them from the very beginning. And so they were funded in 2017 and we've been refunded again in 2022. Just why were we funded? We were funded for exactly the reasons that I outlined here today. American Indian Alaska Natives face significant health disparities. It's been further amplified by a shortage of Native healthcare professionals. And NACO believes there's a solution to all of this and that the solution lies within tribal communities and Native people. So before NACO even came into existence, we actually went to the tribes, the 43 tribes of the Pacific Northwest, and worked with them and asked them, what do you need? How can we make this happen? And so we got buy-in from them before we move forward. Our mission is to work to sustainably address the healthcare needs of all people by increasing the number of American Indian Alaska Natives in the US health professions. So we have pathways all along the continuum because we know that becoming a physician doesn't just start when you get to college. It starts in high school, it starts in middle school. And so we have programming starting at pre-college. We have tribal health scholars, which actually is a paid externship for high school students to shadow in their own tribal communities. We also partner with the Northwest Portland Indian Health Board to do text mentorship as well. In college, we have health pathway coaching. We have someone within our office who meets regularly with students to help them along this way. We have the application phase, we have an applicant workshop, and then we have the Y-East post-baccalaureate pathway, which I'm going to focus on specifically. In medical training, we have cultural enrichment. We have UME, GME electives that we're building out. We're building a Native American pathway so that medical students and residents can go out into tribal communities in Oregon. And then we also are working at the professional faculty level. Because we also, not only do we need American Indian Alaska Natives out in tribal communities, but we need them in academic medicine as well for mentorship. And so we have an Indigenous faculty forum that happens annually and a research fellowship as well. And through all of these, we have visual stories and mentorship. So we believe that Native youth are curious and knowledgeable, that Natives are drawn to STEM, the extra M, there's medicine, fields, and that they are qualified applicants and they're the future health leaders. And so when we started thinking about Y-East in the post-baccalaureate pathway, we looked at data from the AAMC from 1996 to 2018. And we looked at who identified as American Indian Alaska Native and who had applied once to medical school. And they either matriculated or they did not get accepted, and then they never applied again. So we didn't include people who applied a second or a third time and got in, or applied multiple times, never got in. And what we realized is there is this huge opportunity of students who have done all their pre-med requirements. They've taken the MCAT. They have done all these experiences, and they're right there on the cusp of getting into medical school. And so we created Y-East specifically for that. And then when we started thinking about the design of YEast, we looked at the literature and what are some of these barriers to matriculation so that we can be sure that we address them when we were creating YEast. And what we found is that there's often lack of mentorship, specifically American Indian Alaska Native, um, financial resources, no prep courses for standardized tests, feelings of isolation, as well as obligations. And so, what does that mean? That means often having to take care of a relative, or many of these students are non traditional and some of them have dependents. And so, what we really find is there's a huge opportunity for us to address all of these barriers for these students who are right there on that cusp. So, what do we look for? So, Y East capitalizes on the window of opportunity by identifying talented American Indian Alaska Native learners. And so, our pathway is in particular for people who are from federally recognized tribes because of that special political designation. So they have to have applied to medical school unsuccessfully, or they have to be on the cusp of applying, but they lack key components or experiences, such as a competitive MCAT score. And they are otherwise competitive, talented, and committed to pursuing medicine. And we provide them with an educational pathway to become medical students, but also physicians as well. And so just reviewing Y East, it's a 10-month intensive mirror. And so what does that mean? We took the first couple months of medical school, and we actually reached out to the faculty who taught this course and asked them to come teach our Y East post-baccalaureate pathway. And so we're really giving them kind of a running start to medical school, because what we found is that is often the most difficult part of medical school is those first couple months. We mirror the curriculum, and so that means that we have a very similar format in that every Friday, just like OHSU School of Medicine, they take an examination first thing in the morning, um, and so that they're regularly being tested, so they're getting used to that testing environment. Um, we also pay for them to take an external MCAT prep course because this is often one of the biggest barriers to getting into medical school. We have a strong emphasis on mentorship, Indigenous identity, and community. That helps a lot with the lack of mentorship. That helps with the feelings of isolation that happen. We're also tuition free, and we provide a 10-month living stipend, knowing that financial resources are a huge barrier. And it all occurs within the OHSU School of Medicine. And so we wanted to get the students used to being in the environment, knowing how important place-based is as well. And one thing I forgot to mention is that Y East, the reason we named it Y East is Mount Hood. And so you actually can see Mount Hood here in the background of this photo here. I have to give credit to our team. Our team created these slides that we all use for these presentations. So what does the life of a YE scholar look like? So like I said, it's 10 months. It includes that foundational science and medicine. So those are the first couple months of medical school. We also do population health and epidemiology, and we focus on Native American health in particular. And I know Dr. Katie Zuckerman actually used to teach that course for Y East. We also teach academic skills and wellness, so evidence-based skills for learning. Additionally, we have research foundations. They take an external MCAT prep course. They do clinical shadowing, but also we do Indigenous health and wellness. And so this is really this idea that you are coming in with an Indigenous knowledge, and this is important And this is vital, and this is what makes you unique and valued. And so um, it's almost a flipped classroom, if you will. So many of the students come in with tons of Indigenous knowledge. You can be from any tribe in the United States. So we have people from Alaska, we have people from the East Coast, and we come together and do a lot of cultural sharing. Additionally, we teach some of the skills. Um, how do you deal with microaggressions? What's code switching? Some of the skills for students who are coming from underrepresented in medicine backgrounds so that they're better able to be ready for that when it happens. And it probably will happen at some point during their career. So we are now in our 5th year. So 4 cohorts to date have completed Y East. And one of the amazing things about Y East is it has conditional acceptance to OHSU School of Medicine. And so we've actually disseminated and expanded. We've partnered with WSU and UC Davis. And so WSU started 2 years ago and UC Davis started 1 year ago. But we have scholars who come to OHSU who now have conditional acceptance to their school. So 4 cohorts to date, 71% of them have earned acceptance into medical school. 67% have matriculated into medical school, and we have an 89% retention to date in medical school. And so this is looking at the number of American Indian Alaska Native medical students at OHSU. As you can see, we have significantly grown since NACO was established, and we will most likely see this too continue to grow. This is our predicted OHSU American Indian Alaska Native enrollment, actual versus projected. And this is looking not just at Y East alumni, but looking at American Indian Alaska Natives who are coming through the general admission cycle. And so the ones that are former Y East scholars are in purple or in orange, and the number of American Indian students who are coming into the general cycle are in pink or teal. So we're also seeing that increasing number of American Indian Alaska Natives applying to OHSU, most likely seeing that we have built a community here and support surrounding them. So this is a photo from cohort 3. Like I said, we have an Indigenous health and wellness curriculum. We start off with a strength ceremony. We actually hire a tribal elder from one of the local tribes to take us to a sacred site for us to start off the right way with a ceremony, and then we end with a blanketing ceremony. And so this must have been 2021 because we were allowed to gather, but we were allowed to gather in masks. So these are some of our scholars. One of the other unique things I think also is that they are not tied to OHSU. In fact, we've had a number go to other medical schools as well, because really we are just trying to increase the number of American Indian Alaska Natives going into healthcare, and you need to go to where you feel the most supported. So talking a little bit more back about NACO in general. So we are doing creating tons of pathways, but we know that we need to be tracking how we're doing and evaluating the pathways. And so we have an evaluation team. It's Indigenous led, and it's a dedicated team of researchers, and we work collectively together. We meet twice a month to talk about evaluations and papers, and we have 15 publications to date. And I have to just give a big shout out to this group of Indigenous researchers. So as I mentioned, Dr. Eric Brote, one of my mentors, who is the PI for NACO, is here in the middle. We also have Dr. Katie Martin. We have Rosa Frutos, Christy Pinella, Jeremiah Winstrom, Caitlin Donald, Christina and Anna Harris. And so I just wanted to thank each of them today. So I get a lot of questions about okay, what can I do? That's great that you're doing that, but what can I do? And so I always end with these slides, and I want to thank Dr. Um, Philip Champagne, who had some of these slides that I adopted. He's one of the providers at Chemawa Indian Boarding School now. So take the time to learn about the culture and the history of the people living in the area you serve. Recognize how history and culture may affect your patient's health, and have humility. As an academic, mentor, 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 and mentor at all levels: pre college, college, graduate school, residency, junior faculty, associate faculty if you're a professor. As an ally, be trauma informed, or remember how this historical trauma has had effects on American Indian Alaska Natives. We didn't even get today to talk about some of the intergenerational trauma and some of the new research on epigenetics. Have a strength based as opposed to a deficit based when talking about American Indian Alaska Natives. As a provider, ask all your patients, as your provider, what would you like for me to know about any religious or cultural practices that are important to help me know you and your values better? And as a researcher, think about inclusion. Acknowledge when you don't have enough data for American Indian Alaska Natives. Think about data sovereignty. Who owns that data, especially when you're working with communities? Think about a wider context when you're analyzing data. And then ask yourself, who is at this table? If I'm doing research on a population, are they at this table? And so today, we reviewed health inequities in the context of historical trauma. We talked a little bit about Indian health services compared to other healthcare systems. And we described the current efforts and pathways to increase the number of American Indian Alaska Native students going into medicine. And I just wanted to thank some of my mentors who helped me with my slides. Um, and then here are some of my resources. Thank you.
Let's see if we have any questions in the room.
Thank you very much. That was a great presentation. I was really impressed with the inclusion in the evaluation team that you displayed, with the photos and who was there. And wondering, was there any new measures or new metrics or different ways of evaluating your program that kind of came about by having different people at the table?
That is a great question. So I would say really what maybe not necessarily in the evaluation tools that we are using. Other than that, and I should say we also have a couple other people within the Department of Pediatrics who are experts in epi who help us as well, and we sit down with them. But we oftentimes may in the evaluation tools change some of the language so that it's more inclusive. And I would say the big thing is probably when we're thinking about, what does this mean? Why are we seeing this data? And so really in our papers, that discussion aspect is really where kind of that I think Native American perspective comes into play. So we had a paper that came out talking about American Indian Alaska Natives in JAMA, and they actually changed the way that people could identify on applications to medical school from American Indian, Alaska Native to multiple races. And so by allowing that, we had a discussion, for instance, about Native identity and what that means. Very complicated.
Thank you so much for that amazing presentation. I'm a little fixated on that one slide that showcased the numbers of folks, the percentages that matriculated, and acknowledging that percent of folks that didn't quite make it through medical school and training. What are strategies, maybe in the literature or in general, of best supporting folks that go through these sort of pathways once they make it into medical school and residency training? Thanks.
Yeah. No, thank you. So retention is incredibly important because we've invested so much in these YA scholars and for all American Indian Alaska Natives. Um, so we are learning a lot, and I think in Y East, it's a small cohort. It's a small cohort of faculty. And one thing that we are learning is that it can sometimes be a barrier to reach out for help when you're struggling. And so going forward, actually, in our new grant for HRSA, we actually wrote in to be able to support the medical students by having someone within our office be able to meet with students regularly. And oftentimes, it's not the academics, it's the other stuff going on outside of medical school. Helping students through those challenges. We also have the we have an elder in residence, and thinking about, we have that for Y East, but do we need more elder in residences so that they can also help the cultural support for the students, especially as you see those numbers are growing. Um, and so we need to have more people there to support them.
This was more so because the number were changed to happen, we're going to have leaders. Hopefully, some of them not just do with the research. Stanford had from excellence. He developed a program for what you're doing. Encouraging continues to be important. Make sure people understand. That was one of the things we tried to do. So those people are not. Another thing, history, you have. I applaud you for the work that you patient needs to do that. Needs to give back all the things. I think with your colleagues, you're doing that. Any way we can help.
Thank you so much.
Again, thank you so much for the presentation. It was really wonderful. I care for a lot of really sick children, and one of the common themes for patients who are underrepresented is a desire to have important cultural, spiritual, or historically cultural therapies as a part of their care plan. And there's often a lot of resistance due to lack of evidence or concern for causing harm. And in a way, American medical schools are a form of assimilation to a specific type of practice. And so I'm curious as to, in your program, how you address that with your students who might come in with specific medical practices from their tribes or cultures, and how you help them navigate that complexity when there might not be as much medical evidence and literature for those practices.
Yeah, that's a great question. And that's really one of the reasons that we created the Indigenous Health and Wellness curriculum, because we wanted to acknowledge that they are coming in with valued skills. Many of them have been passed down from their ancestors, some of those traditions. And so we try to incorporate that into our Indigenous health and wellness. And it's definitely, there's so many tribes, there's so many different cultures. And so we often ask, the scholars in the beginning, what is important to you? Many scholars, for instance, during our anatomy course, will smudge. And so we've created spaces for them to be able to do that. And we have smudging materials available in our office, and a space for them to be able to do that in a covered area. And so really working to create those spaces. And we're working with like the anatomy lab when we ask them to create this course they really wanted to understand, are there certain cultural practices that we should be aware of? And so we have found ways to work with the faculty as well. But what you bring up, I think, is incredibly important. We don't have a smudging policy, for instance, in our hospital. And that's, I think, really why we need more American Alaska Natives to start pushing for these things so that we can be more inclusive, not just for each other, but for our patients as well.
Thank you.
A couple of questions online. Has the Community Health Workers and Tribal Communities program played a role in recruiting applicants to your program?
That is a great question. So not particularly community health workers, but we have partnered. We have another program at OHSU that works on developing pathways for all underrepresented in medicine. And they have community workers and or I guess I should say educational liaisons that they hire in the community. And so those people are able to kind of help the students, keep them on the same path.
Mm-hmm.
And so they're out there in community, they're understanding, like when we started Tribal Health Scholars, we learned that transportation was a huge issue. So we started providing gas cards to all the scholars, on top of paying them the gas cards for their parents to be able to drive them to these opportunities. And so that was something that liaison was able to communicate to our team.
Thank you so much
Yeah.
for a wonderful presentation.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.